Good morning, friends. Myself, Major Dr. M. Kubek from JK Cancer Institute, Kanpur. I am presenting you before a clinical oncology in palliative setup. Almost, I should explain you the 70% of the people coming in the OPD in the general, the oncology OPD is 70%. Cancer patients require a palliative treatment because you have a locally fairly advanced disease, metastatic disease, in which the radical treatment cannot be executed. So henceforth, we are supposed to give a quick, immediate relief regarding the patient's ailment, and then attendant's panicky. So that I'll be dealing on this topic today. Why palliative setup in oncology is very, very important, because you see the data, only 25% cancer patients are curable. Should oncologist limited to this? Surely not. We cannot only 25% patient, those who are curable, should be treated. Certainly, the 25% patient further can be prevented by developing a cancer, so that we have a new branch, the preventive oncology, in the tertiary care hospitals and advanced regional cancer centers. And the rest 25% patients can be provided a much relief under the palliative care efforts. So that's that 75% of a cancer patients can be directly intervened by the clinical oncologist for regarding the curable treatment 25% for advice of a preventive oncologist to seek to can revert this developing a cancer, and a 25% to be given, and then palliative treatment in form of a chemotherapy, in form of a radiotherapy, in form of plexus neurological plexus block by the help of anesthesiologist. So these we can do it. But what happened to 25% crowd? God better knows. I'm really not in a situation to comment upon it. But certainly, if you are taking care of a 75% of a cancer patients, you should feel proud of it. So that I'll be focusing on that 25% of patients require a palliative setup. The palliative radiotherapy often offers a quick, inexpensive and effective way of reducing many focal symptoms of advanced curable cancers. So it is a quick, it is inexpensive and effective. All three components are there. Whether this tumor arises as a primary tumor or because of metastatic deposits, it can improve quality of life while being associated with limited treatment burden in terms of both hospital attendance and side effects. So that if a bulk of a patients is coming in the government hospital OPD, so that you quickly screen out the patient, those who require a palliative treatment, so that you can give a quick response to them, quick treatment remedy to them, and also you can avoid the unnecessary admission of most of the patients. Those required immediate relief by the help of chemotherapy or radiotherapy. Generally, for the chemotherapy, you require to admit the patient, but at least the radiotherapy can be quickly, palliative radiotherapy can be offered to them, and then you can give an immediate remedy to those crowds. So that palliative radiotherapy can be delivered by the linear accelerator or as well as the cobalt, both. Here you see the linear accelerator. I'm showing it this because of some undergraduate students are also viewers, and some non-oncology other specialties doctors are also viewers of this YouTube channel. So I am telling you about the I'm briefing those that the linear accelerator 6 MV or 15 MV or high energy or low energy, and then another machine you have a traditional cobalt machine, like the oldest one, the 780C machine, of a series of a Canadian machine, cobalt machine, which delivers the palliative radiotherapy. So how is the radiotherapy is delivered? Radiotherapy is delivered with the linear accelerator cobalt machine. Palliative treatment requires lower total dose with a focus shifting to symptoms control while minimizing the treatment burden in the hospital that I've already explained you. This changed the routine delivery of palliative radiotherapy using much shorter course of large fraction size. I mean, the hypofractionation is typically used in the radiotherapy, for particularly in the palliative radiotherapy. The radiotherapy dose delivered to a tumor is usually limited by likely a side effects in the surrounding tissue. So there is always a concern with surrounding normal tissues to give a large hypofractionation dose, so that precise planning is also very important. Advanced treatment techniques that offer the treatment more closely matched to the tumor shape, because a tumor is basically a regular shape, and then also having a three-dimensional picture. So by the help of the multi-leaf collimators in the multi-leaf collimator equipped linear accelerator, we can plan beautifully this tumor to deliver the good amount of radiotherapy while taking care of not delivering the extra dose to the nearby tissues, normal tissues. And then radiotherapy is delivered with a computer tomography on the treatment couch immediately before the radiotherapy. We get a CT simulation done, and then after that you see the CT and then plan accordingly, and they give a radiotherapy instantly. And this therapy the computer CT simulator based radiotherapy, this can more accurately target much higher radiotherapy dose to the small focal disease sites. Increasingly, the advanced techniques are used to offer more precise treatment delivery, allowing the increased dose to the tumor while maintaining the limited dose to the surrounding tissues. And then one of the a good form of a radiotherapy is stereotactic body radiotherapy, stereotactic radiosurgery, stereotactic radiotherapy. So these are the flash radiotherapy. I mean, the different kind of radiotherapies are there to deliver the high dose in the limited fraction, like an SBRT for a lung, and then a 50 gray, 35 gray in 7 fractions, or a 50 gray in 5 fraction for lung and a prostate. We can use the SBRT and then have an equal result along with a long extended duration of radiotherapy. So, but that is for the curative treatment, for a radical treatment. What are the practicalities of palliative radiotherapy? Some legal issues are also there. Patient must be able to provide the informed consent, as well as the written consent should be taken in emergency situation such as spinal cord compression. Quick decisions to be made in the best of the patient interest. The patient must be able to follow the verbal commands. At least he should be able to follow the verbal commands by the radiographers, radiotherapy technologists outside the treatment room, because it is unsafe to deliver the patient if he's comatose, he's not listening the commands. So while moving, so that immobilization, with the help of immobilization devices, we can deliver the treatment. The sedation and anesthesia is not routinely used for a palliative radiotherapy usually, but the anesthesia do have a very, very specific role in the nerve block. Basically, the patients having a severe agonizing pain, celiac plexus block, for a abdominal cancer like a pancreatic cancer or a gallbladder cancer, or brachial plexus block. So the various blocks are there so that the neuropathic pain can be reduced, which is infiltrated by the tumor, the nerve infiltrated by the tumor, and that's not going to be resolved by the traditional painkillers. So palliative treatment are usually delivered as a single dose or a short course, usually 1 to 2 weeks. A close-fitting mask may be needed to ensure the consistent treatment position for treatment to the head and neck and upper chest. This is generally well tolerated even by the more anxious patients, so that the patient is in a mask. The immobilization cost is fixed to the position, because we should know that the 1 centimeter movement can lead to the 5% dose plus minus of a radiotherapy. So that you should be very specific. Like you see here in that patient in the radiotherapy machine is basically a ring gantry machine, and the patient is being put for palliative radiotherapy with the help of immobilization cast. The similar picture you can get in the CT simulation while planning the patient. The indication for using the palliative radiotherapy is palliative radiotherapy rarely improves overall survival, which is rarely improved, but one of the observational studies says the median survival of enhanced by the 5.2 month if a good palliative radiotherapy delivered. So more intention is to keep quick remedy of breathlessness, chest pain, or pain and breathlessness and the various dysphagia, so that you can relieve the patients immediately by the help of palliative radiotherapy. A patient with a particularly limited prognosis, careful consideration of appropriate level of intervention is essential. The potential benefit of a treatment may be outweighed by the expected side effect and the treatment burden. Now, one by one, I'll be explaining about the bone metastasis. Bone metastasis in the cancer patients account 35 to 40% of all palliative radiotherapy treatment. In 35 to 40% patient, those who are going on a machine for a palliative radiotherapy that belongs to bone metastasis. Pain may be constant, intermittent, or a neuropathic with a radiating dermatomal component, and a possible with altered sensation often limits activity of a daily living, performing the routine activities. So that bone metastasis is very, very important for a palliative setups to know about them, and then first localize with the help of CT, MRI and X-ray radiologically where the bone metastasis, then we plan accordingly. Like you see here in this picture in this the coronal view, the lung, you see here the right and left lung, and then one picture with a typical bone metastasis to T8 vertebra, so that usually you take that involved vertebra and 2 vertebra above and 2 vertebra below, because if particularly you see in an X-ray the damage is more than 50%, when more than 50% demobilization of bone have occurred already, then it is evident on the X-ray. But the CT scan and MRI can pick up a very early lesion of bone metastasis. On the other view, you see the sagittal view, the lateral view, that say about the 2 vertebra collapse, 1 vertebra involved, so almost 3 vertebra is damaged, so much of a damage that it is compressing the backside the spinal cord. So that's two problem is there. One is because of a vertebral metastasis, a bone pain, and second is because of the cord compression, the neurological symptoms. Despite the weak opiates, patients have a persistent pain or side effects of a medication must be considered for radiotherapy. Metastasis in a long bone have a risk of pathological fracture. So that you give a radiotherapy so that the bone demineralization becomes stopped, so the patient's pathological fracture may be reduced, the incidence may be reduced. When the risk assessment is to be very, very high, we must get with the help of an orthopedic surgeon. Surgical stabilization is often carried out before the start of palliative radiotherapy. The palliative radiotherapy provides pain relief in almost in a median of 2 to 3 weeks for almost among the 60% bone metastasis patients. The pain relief is there because of a palliative radiotherapy. Whether the pain reoccurs, retreatment may be considered after at least 4 weeks to allow the response. And at the radiation or clinical oncologist kind attention that we routinely use a palliative, single fraction of a palliative radiotherapy in metastatic prostate cancer is almost have an equal result with a single, with the use of intravenous bisphosphonates that like zoledronic acid offer the equal pain relief to the single fraction of a radiotherapy for metastatic prostate cancer. That is study has proven it. So, what kind of fractionation regime recipes we have? The SMO guidelines for dose schedule is 20 gray 5 fraction, but when is to be given 30 gray 10 fraction, when to be given 8 gray single fraction, when to be given 5 gray and 3 fractions. So, the difference between the 20 gray and the 30 gray 5 fraction and 10 fraction is depending upon the patient general condition, life longevity, and how much the serious patient is, her colonoscopy performance score. So these are the factors which involves the fractionation regime. And 5 grade 3 fraction is typically given in the as a hemostatic when the for a bleeding tumors. What exactly cause pain in the bone metastasis? The tumor directly destroy the involved bone, and indirectly the tumor produces the prostaglandin 1, prostaglandin 2 and interleukin 2, which stimulate the osteoclast cells of a bone, which lead to the bone reabsorption and then lead to the further bone fracture and a pain and a fraction. If a patient comes OPD with a pathological fracture of a long bone, what need to be done? The first, you ask the patient the bone stabilization with the help of orthopedic specialist, either by doing the internal fixation that is more radical, or by the immobilization of a long bone like splint, like for femur, tibia, humerus, ulna, and then you go for a radiotherapy. The symptoms due to locally advanced thoracic cancer, the problem arises due to lung cancer or esophageal cancer. The thoracic symptoms include dysphagia among 50%, chest pain 28%, cough 40%, hemoptysis 10% dysphagia, and dysphagia in 7%, dysopnea in 50% cases of thoracic tumors. Should these local symptoms all these local symptoms can be successively palliated in about almost 66% cases of these patients. So that we get relief from dyspnea, chest pain, cough, dysphagia, hemoptysis can be reduced in 2/3% cases by the help of palliative radiotherapy. The palliative radiotherapy to the mediastinum improve obstructive dysphagia from locally advanced esophageal cancer, almost in 2/3 of esophageal cancer patients. Patients clinically significant dysphagia often undergo esophageal stenting before radiotherapy, and then radiotherapy improves durability of swallowing function after the stenting. You see here the esophageal tumor, showing the tumor blockage and the middle 2/3 of esophagus. Then we plan accordingly, and I give a 20 gray 5 fraction of palliative relief, or we can go for a radical radiotherapy 60 gray in 30 fraction. But for palliative setup, you require only to revert the distressing dysphagia, pain. Maximum percentage, almost 70% cases can be reduced because of palliative radiotherapy. Pain in neurological compression due to malignant spinal cord compression. So the malignant cord compression occur when the vertebral disease compresses the cord either directly or as a result of vertebral collapse. The back pain is common, often occurring before neurological sign and symptom, including the sensory and motor disturbance and loss of sphincter control. The urgent magnetic MRI imaging is required to confirm the diagnosis for spinal cord bone metastasis in a spinal vertebrae, and as well as we give it the steroids like dexamethasone 16 mg once daily, is routinely administered with the help of antacids to avoid gastritis. Acquired compression patients should be given urgent radiotherapy within 24 hours of MRI confirmation. Aim is to reduce the pain and retain or improve the neurological functions, because the patient with established paraplegia, less than 10% only regain the mobility after palliative radiotherapy or surgery. So that as much as quickly early we can deliver the radiotherapy to the bony metastasis, that would be very important. The symptoms due to brain metastasis do occur in among 20 to 40% patients in the oncology setup, in the oncology OPD, and that is because of a systemic cancer. Like presentation can be with the seizures, focal neurological deficit, symptom of raised intracranial tension like nausea, vomiting, and the headache. So those limited brain metastasis, a life expectancy of more than 6 months, neurosurgery or stereotactic radiotherapy can be considered under consideration with the treating team. Radiation oncologist kind attention. Again, this slide is important. Those with a more extensive cerebral disease with a retain a good performance status, whole brain radiotherapy can be offered. Indeed, a recent trial demonstrated the no survival or quality of life benefit for the whole brain radiotherapy versus the steroid alone in the patient with the brain metastasis from non-small cell lung carcinoma. That is very important. This is typically slanting field technique of delivering a radiotherapy of brain metastasis. And then another is German helmet technique, but the German helmet is preferred when the meningeal reflections is required to cover, because of that technique involves the meningeal reflections. But for palliative brain metastasis, the slanting field technique is more suitable. So you see here is the brain mets on the there is a single metastasis routinely found in the case of single versus multiple metastasis found in the case of breast cancer versus lung cancer. Symptom due to advanced head and neck cancer. Advanced head and neck cancer patient often present many symptoms like primary side pain, dysphagia, referred pain to the particular that side of the ear, odynophagia, difficulty in swallowing, air compression, can be that will be a bleeding, can be a distressing situation. The prospective studies reported in the pain control and quality of life among about the 50 to 60% of patients after the palliative radiotherapy. We can deliver a radiotherapy as always, ability to eat solids in the patient, those who are having a CS esophagus locally advanced, the difficulty in having a severe painful dysphagia, so we can give a palliative radiotherapy, and that can provide a good relief. Symptoms due to advanced pelvic cancer, like pelvic cancers, can result in a bleeding, discharge, bowel obstruction, urinary bladder disturbance, pelvic pain. Radiotherapy palliated bleeding in UP, bleeding in the up to the 90% of patients. So that palliative radiotherapy with advanced bladder and rectal or gynecological cancer improve other symptoms half to two-thirds of the patients. So you can see here we are planning a pelvic tumor palliative radiotherapy 20-degree fraction. The bleeding, pain, and a mild odor are due to head and neck cancer, due to skin infiltration of a cancer, usually found in the head and neck cancer. And they do well with the palliative radiotherapy in 66% of patients. Most commonly arising from breast cancer, the melanoma, distant metastasis, the routine homeostatic dose for radiation